Hi, my name is Ben, and I'm a health educator here at the Hospital Research Foundation group Arthritis, and I host our webinars. This video features short segments of all our webinars from across 2024. I'd like to start this video with an acknowledgement of country and that we respect and honour the Aboriginal and Torres Strait Islander elders past and present. We acknowledge the stories, traditions, and living cultures of Aboriginal and Torres Strait Islander peoples on this land and commit to building a brighter and better future together. Across 2024, we've hosted 8 different webinars about a wide range of topics about arthritis with world-class experts. Each of these webinars go for about an hour, and you can click the link in each video or down in the description to watch them in full. You can watch back any of our webinars through our website or through our YouTube page. We will continue to host webinars across 2025, and to hear about these, either sign up to our free e-news or follow us on our social media pages.
Just recapping everything: reduce and avoid consumption of ultra-processed foods, drinks, snacks, and processed meats. Increase your fruit and vegetable intake. Eat fruit as a snack. If you're not going to be buying those other processed and ultra-processed foods, probably got a little bit more money budget to buy some of those fruits that you really enjoy: mangoes, peaches, apricots, strawberries, cherries, really yummy. Eat a rainbow of fruit and vegetables, the fermented foods, and trying to reduce your meat intake to having a meat-free day or 2 perhaps a week, replacing it with vegetables, lentils and beans, or rice and pasta in meals, and then replacing the red meat with chicken and fish, and using olive oil, and preferably extra virgin olive oil. Now, we've probably all heard about this, but what I want to do is demonstrate how easy it is to make some of these changes. Now, this is Kevin, and this is what he eats every day. So it's not a bad diet. Muesli with milk. For morning tea, he has a biscuit or cake with coffee. For lunch, he has a cheese, ham, and lettuce sandwich. And he really packs the lettuce in there on white bread and some juice. For afternoon tea, he has a small chocolate with tea. For dinner, his evening meal: pasta with cream sauce, with ham and a side salad, so that's pretty good. And supper and dessert is ice cream or snacking on nuts or chocolate. And this is his usual diet. So we're going to modify this. And if we were all together in the same room, I would have asked for suggestions, but I'm going to do them all here about slight changes in how this can make it a healthier diet. So for breakfast, muesli with milk. I'm going to add some fruit to his muesli and swap the milk for yogurt. So really easy change there, and still keeping the same dairy groups. For morning tea, swapping the biscuits for fruits or nuts. That's an easy change. Lunchtime, so he's got that sandwich. I'm going to get rid of the juice because we know the juice is an ultra-processed food. We're going to use whole grain or multi-grain bread or even sourdough. I'm going to swap out the ham for either chicken or tuna and add more vegetables. Or if you get sick of having the sandwich every day, making a mixed bean salad with vegetables and using extra virgin olive oil on that, and with whatever herbs appeals to him. Afternoon tea, swapping out the chocolate for fruit again, and that way he gets the 2 pieces of fruit a day. Dinner. So we can still have a pasta, but I'm going to have a tomato-based sauce with veggies, and having that onions in there and garlic and herbs. So we've got that tomato-based sauce cooking with the veggies. And then have salad or vegetables on the side as well, of course, with extra virgin olive oil. And, you could add some sort of white meat to this a few times per week. Now, of course, that's just one meal, but there could, there's other adaptations to other meals as well. And then supper and dessert, rather than having ice cream and chocolate, swapping it to dark chocolate, having nuts. Ice cream, lovely, isn't it? But it does contain a lot of that guar gum and potentially emulsifiers in it. So if you make your ice cream at home, it's going to be a better option to have it as a sometimes thing. So that's a modified diet plan. And everyone's probably going, oh, yeah, those changes are simple. But we know it's actually difficult to implement these changes. And what we have to do when we're looking at making dietary changes is use SMART goals. And that is making them specific, measurable, achievable, relevant, and timed. And I'll show you what I mean for this. So, specific. Arthritis, one of the big things we can do is to start eating more fish. So the specific goal here is I will start eating fish I don't eat any at the moment. And after this talk, I'm thinking, yeah, really good that I start eating fish. So I'm going to have a measure to this so I know I can achieve it. I will have fish once per week, even though the evidence tells us it's probably good to have it 2 or 3 times a week. If you make it a big change, it's going to be harder to do. So we'll just stick initially to 1 serve of fish per week to make it achievable. It's relevant because we know fish is anti-inflammatory, so it will help us with our arthritis. And I'm going to put a time to it, that I'm going to give myself a month to achieve this. And you might go, well, why can't you do it straight away? And people might say, well, look, you know, they've got a bit of meat to finish off in the freezer. They've got events planned or their meal plan planned for the next week or 2. It could be they don't actually know how to cook fish. So they might have to watch some YouTube videos to see how to cook fish. And get some recipes that they will like. So this is what we call a SMART goal, and you can convert it to any of the groups you like. Myths. I don't know if we've got time to go to the myths. These are some of the myths around arthritis and foods that cause arthritis. Nightshade foods, no. We know tomatoes are really anti-inflammatory. We know they're a key part of the Mediterranean diet, so they are important. People talk about acid-producing foods. Just quickly want to remind everyone that your body regulates your acid levels no matter what you eat. People also blame dairy foods. That's a problematic group to take out of your diet because of the important nutrients it provides. Some people may say, look, they've got a food intolerance, and every time they consume kiwi or guava, that they just feel they get worse. And what I'd suggest, if it's just one food, it's not a problem. But if it's a whole food group, that's when it becomes a problem and you've got a severe risk of getting a nutrient deficiency.
The Therapeutic Goods Administration, or the TGA, is our Australian government organisation who's responsible for regulating and approving therapeutic goods in Australia. And by therapeutic goods, this includes all medicines, from prescription medicines all the way through to vitamins and herbal supplements. For medicines to be sold in Australia, they have to be listed or registered with the TGA. So basically, we can think of the TGA as our safety net. They take away the guesswork for us in determining which medicines are safe to use. Once the TGA has assessed and approved a medicine, they are listed on the Australian Register of Therapeutic Goods, bit of a mouthful, also known as the ARTG. And these medicines will be assigned either an OST-L number or an OST-R number. So you're probably asking what is an OST-L or an OST-R number? So we'll start with our OST-L, or listed medicines. So these medicines are deemed low risk by the TGA and are listed and assigned an OST-L number. These low risk medicines are less likely to cause harm and contain ingredients generally known to be safe, with a low chance of causing side effects when you're used as directed on the packaging. This might include supplements such as fish oil, magnesium, or turmeric. So they're used for minor health conditions, so simple everyday health problems like a common cold. So listed medicines are not individually evaluated by the TGA, and they're assessed for safety and quality, but not whether it actually works. So the question really is not really whether the listed medicine is going to harm you, it's whether it's actually going to help you at all. OST-L or listed medicines can only make low-risk claims, and to make a claim about a product, the TGA requires a company to certify that they hold evidence to support the medicine actually works. The key word here is hold. They don't actually have to show the TGA the evidence for it to be sold in Australia. The company basically just has to promise they have it somewhere in case they're audited. And there is a predetermined list of ingredients and amounts of these ingredients that are set out by the TGA that listed medicines are allowed to contain. So as long as companies are following this list, then the TGA consider these products to be low risk. The TGA will actually review random products that are marketed in Australia. And if a company is audited or reviewed, the company might be required to provide the evidence of efficacy and that they're actually following the TGA rules. If that particular product does not comply, the product might be suspended or it might be completely removed from sale. Medicines that are considered high risk or higher risk by the TGA are registered or assigned an OST-R number. And they're used to treat more serious illnesses such as rheumatoid arthritis. These will include all prescription medicines, so things like antibiotics or blood pressure medicines, many of the over-the-counter medicines, for example, Panadol or paracetamol, and even some complementary medicines have an OST-R or a registered product. They're mainly purchased from pharmacies, but they can sometimes be found in supermarkets. So things like Panadol and Nurofen are registered products, but they can be found in like your local Coles or Woolies. And again, on screen, you can see just a selection of our medicines that are registered products in Australia.
So to recap everything, we can see OST-R or registered medicines have been assessed by the TGA for all three aspects of safety, trustworthiness, so the quality, or efficacy. Does the medicine work? OST-L or listed products are approved for safety and quality, but are not required to prove they actually work before entering the market. And unregulated products are not assessed for anything and are very risky with great potential to harm. So we do not recommend purchasing unregulated products.
All of the research is pretty clear that when we're looking at doing exercise, we should be prioritizing strength exercises that strengthen specific functional movements. So if we want to get better at getting in and out of a chair, we should be practicing variations of getting in and out of a chair. If you want to get better at swimming, cycling won't help you. Even though I can touch type, I can't play the piano, even though it's exactly the same finger movements. Playing basketball isn't going to make you better at darts. Essentially, what we need to be looking at is doing the movements that we want to get better at, but just finding easier variations of those movements. So the take-home message there is when we're looking at getting stronger, when we're looking at getting more functional, we need to be appropriately selecting those exercises which mimic the things that we need to do in real life. Unfortunately, sitting down in a chair and doing leg extensions has very, very, very little impact on how easy it is to actually get out of that chair. Practicing all the side leg raises in the world isn't going to help you get on and off the ground. We have to practice those movements. So the next point we want to make is we've made it pretty clear, and this is a pretty funny diagram, I made this one up, that strength training by itself doesn't improve your balance or your ability on and off the floor. Just because you lift a weight above your head X number of times doesn't mean you can do a handstand. But what it can do is it can take up your valuable time and make you tired and detract from doing the important things that will help you achieve your mobility goals. So I think this is a pretty cool little video here where we've got someone demonstrating how some of the important movements that we should be practicing relate to what we actually do in real life. Essentially, practicing variations of lifting, lowering, pushing, pulling, and carrying makes us better at lifting, lowering, pushing, pulling, and carrying. Oops. But it's important to note though, and this is super important when we're considering arthritis, and some of you may be familiar with the GLAD program. This is a slide in the GLAD presentations. When we're looking at both arthritis and strength training, it's not necessarily that any exercises are bad. It's doing too much of a good thing is bad. Conversely, doing nothing is bad as well. Doing no exercise is terrible for arthritis. If we don't have the joint nutrition, we don't have the lubrication within our joints. If we do too much, it can irritate things. It can make it sore. It can make it overworked. So we need to find essentially the Goldilocks approach, doing just enough to create a change in our body and make us fitter and stronger, but not so much that we're going to overload things. So how does this relate to exercise selection? So when we're looking at some exercises, like we can see in the top here, the seated leg extension and the side leg raises, don't get me wrong, those movements can be quite good from a general perspective. They can be good at joint nutrition, in general muscle health, in muscle strength as a whole, but they don't necessarily translate to functional movements and getting better at getting in and out of the car, on and off the ground, or off a low toilet. So if we swap those exercises for movements that replicate what we need to be able to do in real life, for example, squatting down, getting in and out of a low chair, step ups to get on and off, up and down a gutter, going up and down stairs, we can get the same general benefits as those top exercises, but we also get the specific benefits of getting better at those everyday movements. Now, just a word of caution. If you are already doing those top movements and you're doing like some seated exercise program, or you're going somewhere and you're doing side leg raises and rear leg raises and marching on the spot, take caution when it comes to adding in the functional movements on top of what you're already doing. That's where we can be doing too much too soon. And from an arthritis point of view, though you may end up getting sore, doesn't mean that the new exercises are bad, but it can be a sudden increase in activity, and that load management is super important. So we can start off with those functional movements which have the generic benefits to our joint nutrition and health and our pain, and they also have those specific benefits. And as we become more familiar with those and our body is more accustomed, we can slowly add back in the other, what I would say, less important movements, if you like. But the key thing is we need to be looking at a gradual increase. If we go back to doing squats and step ups and things, and then whack back in a whole myriad of other specific isolated joint movements, we can get back into that same position of being overloaded. So the whole point is start slowly and gradually build back up. So the take-home message there is there's an opportunity cost of doing the inappropriate exercises. Some exercises are good for the joints and muscles, but they don't make us better at what we need to do. And they take up our time, and we can end up getting sore if we're doing too much. So we need to choose wisely. So the third point is using graded exposure to minimize joint irritation. Now, if all of a sudden we embark upon a new exercise program and we, New Year's Day, and we've got the New Year's resolution, we might decide to go, you know what, I've got this goal. I want to be able to do X in 10 weeks' time and do a lot of activity too soon. What then happens is we go through this series of peaks and troughs where we do a lot of exercise and our body responds by saying, that's not cool, I'm going to make you sore. And so then we do nothing for a long time. And then we get all motivated again a few weeks later and we do a lot again. And we have that rebound effect where we get irritated and again, we do nothing. Where what we should be looking at doing is starting off slower than what we think is necessary and just gradually adding things in. So we're really sneaking up on our body and allowing those adaptations to occur over time. We need to allow our joints, our muscles to gradually become accustomed to the load we're putting them through, but at the same time, allowing painful joints to desensitize as well. Now, we've already talked about the types of exercise and the importance of choosing exercises that are functionally relevant. But here's where it's really important that we think about the frequency or how often we're exercising, most importantly, the intensity, but how much of it we're doing as well.
So I'm doing them together because there's a lot of overlap between Sjogren's, which is now called Sjogren's disease rather than syndrome, and it's systemic lupus erythematosus, which we either shorten to SLE or lupus. So both of them are autoimmune conditions, meaning the body's natural defense system, being the immune system, attacks itself. It may affect multiple organs, but it can be very mild and can be very severe. So everybody's different. It tends to be lifelong, or both of them. So chronic, they may relapse, they may remit. So you may have years without any problems, or some people have problems all the time from them. So very variable. Many shared features between Sjogren's and lupus, being the autoantibodies. So anti-nuclear antibodies are the main ones. Then there's another number of autoantibodies, but particularly the anti-Ro or SSA can be seen often in both of those disorders. And the way they can affect the blood and the risk factors for getting them in the first place, the genetics that we know about so far are shared between the two disorders, with some different and many the same. Drugs are mainly, there are certain drugs that can bring on lupus, but none have really been defined for Sjogren's, so that's a difference. Sjogren's is very common. It's about 1 in 100 people, so it's similar to rheumatoid arthritis, and it's very female directed, so about 20 females to 1 male are affected, and the age of the peak onset is between 40 and 60 years of age. So the lupus is less common, so about 1 in 1,000 in Asia, perhaps 1 in 10,000 in Caucasian Australians, 1 in 500 in African Americans. So it varies around the world. But again, it's 10 women to 1 man, but a younger age. So the peak incidence is between 15 and 45 years old. So very overlapping disorders, but different age groups and different prevalence. Both can really impact people's well-being though, particularly with fatigue, pain, and in the case of Sjogren's, dryness. We'll talk about that later. And there are implications for both of these diseases on pregnancy for mother and baby, and we'll talk a bit about that too. So I don't want you to memorise this, but it's just to show that the diagnosis of lupus, even for doctors, is quite complex. In lupus, we think the immune complexes, these big nets of antibodies, play a big role by being turned on in the immune system and depositing in the bloodstream, in the blood vessels, in the kidneys, in the skin, and turning on the immune system to attack those areas. But in real life, in the clinical situation, we can make a clinical diagnosis of lupus based on, antibodies and clinical features, and it might be early. There might be only one typical clinical feature to date. But, just so that you can see how complex it is for even doctors to understand what they're looking for to make a diagnosis. In Sjogren's syndrome, we really think these boss cells, the T cells, driving the B cells are the main players. So not the immune complexes so much, but the cells getting into the organs and the glands. So particularly the salivary glands here, the main ones, and there's a lot of little ones lining the mouth, and the tear glands up above the eyes that aren't shown here, get invaded. You can see on the right, all of these little purple guys are these cells, B and T cells, invading a gland and stopping it from working properly. So the people mainly, characteristically complain of a dry eye. And on the left, you can see that cloudy bit on the eye is an ulcer. So they can get ulcers and infections and even lose vision. But typically there's a dry, very irritated eye, feeling like something's in it. And the eyes get tired reading. The dry mouth can lead to a lot of dental problems over time. And that's a major damage from having Sjogren's or lupus, which can have Sjogren's on top of it. And people often have these very sore, swollen salivary glands as well. And as I mentioned before, Sjogren's can have all these other organs being affected as well. So the diagnosis of Sjogren's is even harder. So it's a combination of how much saliva you produce, how many tears you produce, what the surface of your eye looks like, if there are any little areas where cells are missing from the dryness. A blood test for the autoantibodies. I mentioned the anti-Ro, which is one of the subsets of anti-nuclear antibodies. And then the biopsy, the salivary gland biopsy. Not all patients have to have all of those tests, but we really want to show that there's dryness, and we want to show that there is an autoimmunity going on to cause the dryness, because actually there are hundreds of causes of dry eyes and mouth, including menopause, many drugs, diabetes, and so forth. So for Sjogren's, we need to show autoimmunity either by the biopsy or that Ro antibody in the blood.
Of the 3.5 million Australians who have arthritis, 1 million also have a mental health condition. So this translates into almost 1 in 3, or at least 1 in 4 of those with arthritis who will also have a mental health condition. Research published on this topic also supports that there's an increased risk of depression and anxiety in arthritis. So this study analysed data from 17 countries who completed the World Mental Health Survey. They found that anxiety and mood disorders, such as depression, were almost twice as likely amongst those with arthritis compared to the general population.
So as Bethany said, it's really normal for these sorts of emotions to affect people who have chronic illnesses of all sorts. And of course, in terms of managing pain, we know that really pain is not just biological when we experience it, even in the context of an illness like arthritis. There are biological factors, of course, that contribute to pain, but so are there psychological factors, social factors, and behavioral factors. So what you do also really contributes to it. And I guess one of the things that's really important about interventions in terms of trying to ensure that you get actually, the best interventions for your quality of life is that there's often a lot of focus on the biological factors. So certainly we know that it's very important in arthritis for you to have access to medications that can help to control inflammatory processes and so forth. You may well be taking other pain relieving medications or other physical treatments like acupuncture or physical therapy, and those things are really important. It's also really important in terms of thinking about what to do to really understand the arthritis that you have and the importance, for example, of balancing rest and exercise when your joints are inflamed, in trying to ensure that you have lots of good support in your lives. But also there are some treatments that are very helpful specifically on the psychological point of view, and that's what I'm going to really talk about this afternoon. And if you see in the right-hand corner on your screen, there are some treatments that have been demonstrated to be effective in terms of reducing mental health, particularly in the context of pain and arthritis. And the two most common of those that I'm going to talk most about tonight are cognitive behavior therapy and mindfulness. And I'm going to talk to you actually about a study that we've just finished comparing the effectiveness of these two treatments. What does this mean for you guys if you're thinking about getting an intervention to help you manage your arthritis better and to manage any mental health consequences that you might be experiencing from living with arthritis? First of all, I think it's a really good news story. We were able to show that online in a program where people had access to support once a week, but we found had less than 10 minutes of support on average throughout the program, that both CBT and mindfulness led to improvements in symptoms, although there were some changes that were different between them. Importantly, in some of our analyses, what we found is that people who already are quite mindful and like the idea of mindfulness actually did better with mindfulness-based stress reduction. And we also found that it was actually those changes for people who had in fear of progression over treatment that led to the changes that people subsequently had in terms of functional ability. And so this suggests that if fear of disease progression is an issue, and that's something that you're worried about, that mindfulness might actually be the treatment of choice, particularly if you have relatively lower levels of pain. However, those who had higher levels of pain did seem to benefit more from CBT. And so if you were someone who had a lot of pain, CBT might be a good option in that case.
I've just got a couple of pages with some helpful resources and contacts. So that first dot point is about the GP. So GP is a great resource to go to who can help devise a mental health care plan, which can give you access to 10 subsidized or free mental health sessions, as well as discussing medications like anti-anxiety and antidepressant medications. I've also got that dot point about psychologists. So you can use that website to find a psychologist in your area and also specify for what sort of support you're needing as well. We've also got a couple of crisis services, so Lifeline and the Suicide Callback Service, which are both 24/7 hotline supports. We've also got Beyond Blue down there, the Men's Line, and 13 Yarn. On the next page, I've just put the links for some of the free online therapies that are available that Louise did mention. So MindSpot is the one that's run by Macquarie, This Way Up, and the eCentre Clinic has the pain course as well, specifically available, as well as some mindfulness applications. So Smiling Mind is a free application as well, and also Headspace and Calm.
So some of you might have heard of clinical guidelines before. Basically, these are big fat documents that bring together all of the research for a particular health condition, and they summarize which treatments work the best. So for osteoarthritis, all of the major clinical guidelines from around the world recommend education, exercise, and weight management as the best treatments for osteoarthritis because they're particularly good for reducing pain, increasing mobility, and improving quality of life. But what's really important about these guidelines is that they all recommend that everyone should try these treatments before having surgery, no matter how severe the osteoarthritis looks on a scan or an X-ray. And these treatments can actually prevent or delay around 75% of surgeries for at least a year. So they are quite effective. So one really effective way that we educate people about pain is by telling amazing pain stories. So these stories really illustrate how pain is actually much more complex and complicated than we think. It's not just a direct measure of how much damage is happening in your body. So for example, most of us have heard stories where people have had a serious injury, but no pain at the time of that injury. Like when President Reagan was shot, a bit topical, he's on record saying that he felt no pain at all when that happened. Or when people who have been attacked by a shark, even when they've had an arm bitten or ripped off, they often report feeling no pain at the time and only feeling a bump. And the reason for this is because when we're being attacked, our main priority is to get to safety and survive. So our clever brains minimize the pain experience and redirect our resources towards what's best for survival. So for a shark attack, this would be to swim to safety. Having lots of pain while you're trying to get away would not be very helpful at all. But then after we get to the beach and we're safe, we will start to feel pain because the priority has now shifted to needing to protect and heal the injured body part. But the ratio of pain and damage also swings the other way. So if you think about a paper cut, there's really not much damage at all, but they can really hurt. And this is because paper cuts often happen when we're in a really safe and potentially boring environment, like when we're at work. And we can even have pain in a body part that doesn't even exist, like with phantom limb pain. So this example is really fascinating because it tells us that there doesn't even need to be a body part there at all, and we can still feel pain there. So all of this tells us that the amount of pain we feel doesn't necessarily relate to changes in our joints. And this also means that even if we have an increase in our pain, it doesn't necessarily mean we've done more damage. And this is because what's happening in our bodies and in our joints is only one part of the complex pain experience. So we can really use this knowledge about pain to our advantage. Understanding the other things that contribute to our pain can help get us on the pathway to less pain. So one way we educate patients on how to do this is using the concepts of DIMS and SIMS. So DIMS means danger in me, or things that might increase our pain. And SIMS means safety in me, or things that might decrease our pain. And as you can see here on this slide, there are 7 different categories of DIMS and SIMS. And what we do is we go through each of the 7 categories to find all of our DIMS and SIMS, including the tricky and unexpected ones. So I'm going to talk you through each of these categories one by one and give some examples. But everyone has their own unique DIMS and SIMS. So as I go through each category, I want you to try to think of a DIM and a SIM that might be relevant to you and your pain. Before we get into exercise, I do just really want to acknowledge that exercise is not always easy. It can actually be really hard, especially when you are in pain. You might have even tried an exercise program before, but it just made your pain worse. And we hear this all the time. It's really, really common. So today we're going to share with you some tips and stories to try to make exercising a bit easier and hopefully more effective as well. One thing I want to point out here as well is that the new science, the really new science, is actually telling us that our weight is not the only important factor for osteoarthritis pain, and that actually a healthy diet, even with no weight loss, can be helpful because it can reduce what we call body-wide inflammation. So we've actually recently discovered that this body-wide inflammation is actually one of the important drivers of osteoarthritis pain. So now, instead, we try to get people to focus on nourishing to flourish, and that weight loss should not be the only goal, and that you haven't failed if you haven't lost weight.
So podiatrists, what do podiatrists do? Well, we diagnose and manage problems with disorders, injuries and pain affecting primarily the feet, but also very much associated the next door joints of ankles, knees and legs. Some podiatrists also prescribe medicine as endorsed prescribers, particularly some anti-inflammatories and analgesics or pain relief. So podiatrists are about supporting health by supporting foot health, and very much about supporting mobility and independence. And that's all about strength and balance, warding off falls, keeping people active and maintaining quality of life for as long as physically possible. And we know that moving and strength are the 2 critical things that make a difference to people's quality of life at all ages, particularly as people get older, and particularly if people have conditions like one of the arthritis family. Keeping moving maintains strength and offsets some of the pain. So the main points I'm going to be trying to get across to you tonight are the importance of exercise, and I think we've probably established that. Another thing that's really important as far as feet are concerned, and a concern for podiatrists, is people's body weight, because we know that when people are carrying too much weight, that's not good for foot pain and it's not good for health. And then the other thing, as part of both of these we'll talk about, is footwear. So exercise, body weight and footwear are the 3 things we'll address. It's worth looking at some of the recent research. This is from 2023, that across the community, foot pain increases as people get older, so that 1 in 3 middle-aged to older adults have foot symptoms, which are defined as pain or stiffness or aching on most days. So that's 1 in 3. That's independent of conditions like arthritis. But those who are more likely are females, those who identify as Black, those who are obese or overweight, those who are older, or those who are on their feet doing routine manual occupations. And the figure seems to be where 5 or more hours on your feet a day sees people more represented as having foot pain. Foot pain and symptoms are associated with less physical function and more disability, particularly as time goes by. And that affects independence and participation in work and social activity and anything that involves physical movement. Foot symptoms due to osteoarthritis have actually been associated with a shorter lifespan, and it's probably because people move less, become weaker, and then are more likely to fall. So this association between moving less and getting weak and falling, we need to be very well aware of, which is why exercise is so important and always something that a podiatrist is looking at. Exercise, if someone has been very inactive, we need to get people exercising gradually, and then maintain that as their strength improves. Body weight, if someone's body weight is really high, then that's something that we can't change quickly, but it needs to be addressed as well, but clearly takes longer. Footwear, on the other hand, is something that we can address quite quickly, and sometimes that alone can have significant effects to someone's pain, comfort, movement, quality of life.
What are the arthritis-specific challenges that can impact on continence? So it's primarily going to be a situation of being able to get to the toilet on time. So getting to the right space with your clothes down, sitting safely, or standing safely if you're a chap. And so for people with arthritis and the various challenges they may face with joint pain, stiffness, that may affect their ability to get to the toilet. It may affect their dexterity for dressing and undressing. The other aspect that links back to arthritis is constipation, which may be pain management induced. So when people are needing to use opioid type pain management, then they have got a higher risk of developing constipation as a side effect of that drug regime. The other potential causation for incontinence symptoms might be urinary tract infection, and that may be a sequelae to poor dexterity leading to poor hygiene in the toilet. And so if people are unable to wipe themselves effectively or have had to change their position to reach, then perhaps they've not been able to maintain enough hygiene to prevent urinary tract infection. The other area that is very much a watch this space is the role of inflammation. So we know inflammation is a component of the arthritis pathology, but there are certainly some links with bladder conditions being bladder conditions being an expression of an inflammation disorder or an immunological disorder. So it's an area that I can't comment specifically about, but it's on the watch this space perspective. Some tips and strategies for people who are looking at how do I make choices to support functional continence. So functional continence is the ability to get to the toilet at the right time, okay? And the first thing is, so I've put up the home is where you trust the toilet seat, as just to set the scene that in the home environment, people who are dealing with mobility issues, they may end up making some decisions about changing bedrooms in order to be closer to the toilet if they've got an issue overnight. That if they've got upstairs toilet, downstairs toilet, thinking about accessing toilets in those regards. You're thinking about the layout of your house, and what it takes for you to be able to get to that toilet. In terms of getting there, this is where sometimes people, I'll start with general exercise and pain management. If you've got arthritis, I'm sure you're aware that through exercise that targets your needs and pain management that manages your pain successfully, then that's going to result in better mobility. So you're going to be able to move to the bathroom with more comfort, more speed, more balance, so that as you're on your way, you're not at risk of losing control in the process. Okay. The other consideration is dress for success. This is where, again, sometimes the type of clothing that you might choose to use if you've got a continence issue could be worth considering, something that's easy to get on and off, particularly if your dexterity is starting to struggle, so your hands are having trouble with buttons and zips, thinking about those sorts of choices and maybe adapting your clothing. Continence products are also a valid choice for functional and social continence. So that's where you've got the backup of a pad or a product that you can wear, so that if you are unable to get to the toilet on time, then you've not had a leakage event that's caused you social distress. Okay. In the last page, where we've got information about resources, there's also some details on how to choose the right continence product for your situation. Okay. And there are also financial resources available from the government to put towards the cost of continence products if you require them in an ongoing way.